All right, thank you for having me, everyone. I'm excited to be here. I'll try and talk as loud as I can to get you at the back. I am suffering a bit of a cough, so my voice might kind of trail off at some point. So if you can't hear me in the back, you can always just raise your hand and I'll try and talk louder. I've included a lot of video in this lecture to account for some of the language barrier if English is if you're not as fluent in it. I've included a lot of video to kind of demonstrate a lot of the points that I'll go over. As well as Katerina, or Dr. Dounavi. She's done about a 7-minute presentation just to give you a bit of an overview in Greek of what my presentation will be on, just to provide some more background information. So we'll start with that first.
Καλημέρα σε όλους. Είναι μεγάλη μου χαρά που συμμετέχω και φέτος στο 4ο συνέδριο της Ελληνικής Κοινότητας Ανάλυσης Περιφοράς. Ευχαριστώ για μια ακόμη φορά για την πρόσκληση. Σήμερα θα σας μιλήσουμε για ένα πολύ ενδιαφέρον ερευνητικό πρόγραμμα που έχω αναπτύξει στο Queens τα τελευταία χρόνια. Θα σας δώσω λοιπόν περιοδικά κάποια στοιχεία για το πρόγραμμα και στη συνέχεια η Amy Tanner, διδακτορική φοιτήτρια του Queens, θα σας δώσω περισσότερες λεπτομέρειες. Το πρόγραμμα επικεντρώνεται στην παρέμβαση για παιδιά βρεφικής και πρώτης νηπιακής ηλικίας που εμφανίζουν σημάδια αυτισμού. Όπως γνωρίζετε οι περισσότεροι, η διάγνωση του αυτισμού βασίζεται σε δύο αναπτυξιακούς τομείς, την κοινωνική επικοινωνία και την επίδραση και την παρουσία των αναπανόμενων και περιορισμένων συμπεριφορών. Η διάγνωση μπορεί να βοηθήσει τα δύο έγκυα μια αξιοπιστία και να παραμείνει σταθερή κατά τη διάρκεια της ζωής του ατόμου. Δυστυχώς όμως η διεθνής πρακτική επιβεβαιώνει ότι στις περισσότερες χώρες τα παιδιά λαμβάνουν τη διάγνωση μετά τα 4 έτη. Τα πρώτα συμπτώματα, οι σημάδια αυτισμού, οι μελέτες δείχνουν ότι είναι παρατηρήσιμα από τους 6 έως 12 μήνες ηλικίας, ενώ οι γονείς συστηματικά αναφέρουν τις πρώτες ανησυχίες τους πριν τα πρώτα γενέθλια του παιδιού. Η ανίχνευση αυτών των σημαδιών είναι πλέον δυνατή σε βρέφη, καθώς οι πρώιμοι συμπεριφορικοί δείκτες εμφανίζονται ήδη από το πρώτο έτος ζωής. Μάλιστα, οι ειδικοί μπορούν πλέον αξιόπιστα να τους αξιολογήσουν την ηλικία των 12 έως 18 μηνών. Γνωρίζουμε με βεβαιότητα ότι η παρέμβαση που ξεκινά πριν από τους 24 μήνες προσφέρει τα καλύτερα δυνατά αποτελέσματα στο παιδί και την οικογένειά του. Αυτό οφείλεται σε έναν βαθμό στο γεγονός ότι η πλαστικότητα του εγκεφάλου σε αυτή την ηλικία βρίσκεται σε πολύ υψηλά επίπεδα. Μέχρι σήμερα, τα πορίσματα των μελετών έχουν περιγράψει διαφορές μεταξύ των παιδιών που αργότερα στη ζωή τους έλαβαν τη διάγνωση του αυτισμού και των παιδιών τυπικής ανάπτυξης στον τομέα της κοινωνικής επικοινωνίας. Για παράδειγμα, τα παιδιά που αργότερα στη ζωή τους έλαβαν την διάγνωση του αυτισμού παρουσίαζαν διαφορές στη συχνότητα και την ποιότητα της βιωματικής επαφής, στο κατά πόσο προσανατολίζονταν προς τον μήνυκα που φυτακώναζε με το όνομά τους, στη συχνότητα του βαμβίσματος, τη μίμηση, το κατά πόσο μπορούν να ακολουθούν το βλέμμα των άλλων, να δείχνουν το δάχτυλο κλπ. Επίσης, έχουν παρατηρηθεί σημαντικές διαφορές στον τομέα των κινητικών αλλά και άλλων δεξιοτήτων, όπως τη δυνατότητα αναγνώρισης προσώπων και την οπτική παρακολούθηση. Και επίσης έχουν παρατηρηθεί διαφορές στις επαναλαμβανόμενες συμπεριφορές, όπως την παρουσία στερεοτυπικού κινητικού, αλλά και επαναλαμβανόμενη κινήσεων. Όσο η μέθοδη έγκαιρης ανείχνευσης των πρώτων σημαντικών αυτισμού βελτιώνεται, τόσο αυξάνεται η μεγάλη επιστήμη επιστημονικά και την ενδεδομένη μεθόδου παρέμβασης για βρέφη κινείται κάτω των 18 μηνών. Μέχρι σήμερα, το 5% των μελετών μόνο έχει επικεντρωθεί σε κοινωνικά καθημερινές παρεμβάσεις για τον αυτισμό σε παιδιά μικρότερα των 3 ετών, και ένα πολύ μικρό κομμάτι αυτών τα έχουν και συμμετέχοντες παιδιά μικρότερα των 24 ή των 18 μηνών. Αυτές οι μελέτες έχουν αναφέρει μέχρι σήμερα μια πάρα πολύ σημαντική αλλαγή στην αναπτυξιακή πορεία των παιδιών που έλαβαν πρώιμη συμπεριφορική παρέμβαση, με το 18% περίπου των παιδιών να χάνουν τη διάγνωση και να μην είναι διακριτά από παιδιά τυπικής ανάπτυξης σε αργότερα στάδια της ζωής τους. Μάλιστα, αυτές οι σημαντικές αλλαγές έχει φανεί ότι διατηρούνται μακροπρόθεσμα σε μελέτες που αξιολόγησαν αυτά τα παιδιά στην εφηβική ηλικία. Οι μελέτες που έχουν επικεντρωθεί στην πρώην παρέμβαση με βρέφη και μύτια έχουν λάβει υπόψη τους ότι το παιδί σε αυτή την ηλικία περνά το μεγαλύτερο κομμάτι της ημέρας του με τους γονείς του, οπότε όταν σχεδιάσουμε μια παρέμβαση που θα θεωρεί τους γονείς ως τους βασικούς μεσολαβητές, μας οδηγεί στο να έχουμε ένα πρόγραμμα που είναι εφικτό, κατάλληλο ηλικιακά αλλά και αποδεκτό από την οικογένεια. Μάλιστα, οι μελέτες μέχρι σήμερα μας δείχνουν ότι οι παρεμβάσεις που έχουν τους γονείς ως μεσολαβητές έχουν τεκμηριωμένη επιστημονικά αποτελεσματικότητα. Αυτού του είδους παρεμβάσεις λοιπόν μέσα από το παιχνίδι αλλά και άλλες ηλικιακά κατάλληλες δραστηριότητες όπως το μπάνιο, το άλλαγμα της πάνας, η βόλτα, το φαγητό κλπ. Μας επιτρέπουν να διδάξουν κέρυες δεξιότητες παιδιά αυτής της ηλικίας. Το ερευνητικό πρόγραμμα λοιπόν που έχουμε σχεδιάσει στο Police και το οποίο είναι να σας δώσω περισσότερες λεπτομέρειες είναι καινοτόμο για τα ευρωπαϊκά και τα ελληνικά δεδομένα. Οι συμμετέχοντές μας είναι παιδιά ηλικίας 12 έως 24 μηνών. Έχουμε πραγματοποιήσει πρωτότυπα πειράματα που βασίζονται στην πειραματική μέθοδο της εκτεταμένης ατομικής ανάλυσης της συμπεριφοράς. Η παρέμβαση που έχουμε σχεδιάσει δίνει έμφαση στην ανάπτυξη του λόγου και τη διδασκαλία μιας αναπτυξιακής αλληλουχίας κέρυων δεξιοτήτων που τα παιδιά αυτής της ηλικίας χρειάζεται να κατακτήσουν. Οι γονείς είναι οι βασικοί μεσολαβητές και ο πιστοποιημένος αναλυτής συμπεριφοράς ή PCB τους καθοδηγεί. Το πρόγραμμα ξεκίνησε με τη δουλειά της ΕΕ στα πλαίσια του διδακτορικού του στον Καναδά και αυτή τη στιγμή βρίσκεται σε εξέλιξη σε άλλες χώρες. Τα πρώτα αποτελέσματα από αυτό το πρόγραμμα που αποτελούν τη μελέτη που πραγματοποίησε η ΕΕ για την διδακτορική της διατριβή δείχνουν ότι σε 4 περίπου μήνες παρέμβασης πετύχαμε μια πολύ σημαντική όθηση στην ανάπτυξη των παιδιών που συμμετείχαν στη μελέτη. Συγκεκριμένα, σε 4 μήνες τα παιδιά εμφάνισαν πρόοδο 14 μηνών στις δεξιότητες αντίληψης και 15 μηνών στις δεξιότητες έκτασης. Αυτό ισοδυναμεί με 10 επιπρόσθετους μήνες πρόοδου που δεν θα περιμένουμε τα παιδιά να δείξουν χωρίς την παρέμβαση. Οι μελέτες υποστηρίζουν την χρησιμότητα της πρώιμης παρέμβασης και τα πολύ σημαντικά αποτελέσματα που μπορούμε να πετύχουμε όταν η εκκίνηση γίνεται στην ηλικία των 12 έως 24 μηνών. Καταφέραμε να δημιουργήσουμε μία διδακτική αλληλουχία κέρυων δεξιοτήτων, η οποία αποδείχθηκε αποτελεσματική για παιδιά αυτής της ηλικίας, η οποία μάλιστα έχει ένα εξαιρετικά μειωμένο κόστος τόσο για την οικογένεια όσο και για το σύστημα υγείας, σε σύγκριση με μια πιο εντατική παρέμβαση που ξεκινά αργότερα στη ζωή του παιδιού. Στη συνέχεια, λοιπόν, η ΕΕ θα σας δώσει περισσότερες λεπτομέρειες, τόσο για την πρώιμη ανίχνευση των πρώτων σημαντών αυτισμού, όσο και για την παρέμβαση που βασίζεται στην ανάλυση συμπεριφοράς, που οδηγεί σε αυτά τα εξαιρετικά αποτελέσματα σε βρέφη αλλά και παιδιά ανηλικίας ηλικίας. Ευχαριστώ πολύ για την προσοχή σας και καλή ακρόαση στο υπόλοιπο συνέδριο.
I'm not actually sure what she said there, but hopefully nice things. So I feel, yeah, you've already received a bit of an overview about me. So yeah, I've specialized in early intervention with children with autism for about 11 years now, working in the south of France, in Egypt, as well as in Canada. I've been a BCBA for the past 6 years, and I was a clinical supervisor for the largest clinic in Canada. It had about 250 kids in it and 120 under the age of 6, so it was quite a large intervention clinic. Presented research across Canada, US, Sweden, Italy, France, Germany, the UK, and Japan. So any opportunity I get to travel, I take on it, which is one of the reasons I'm here. I've also never been to Greece. And I volunteer with the Global Autism Project, so I've helped set up clinics in Indonesia and the Czech Republic on behalf of them. So I'm going to show lots of video throughout this lecture. If they've got, what I ask is through all the videos not to take pictures of the video. The ones that have the blue icon, they'll be provided on the video that's recorded. The ones that say don't film, the parents don't want those videos posted, but they're happy to provide them or provide consent to share in a lecture like this. So what we'll be looking at today is looking at what pre-diagnostic intervention looks like and what that refers to. What are the earliest signs of autism? So how early can we intervene, and what are those signs that we're looking for? I'm going to share some of my research, so the pilot and main study that was part of my PhD. And then also a curriculum I've put together about what to target in young infants and how you can sequence that. And so if you're working with really young children, you can be able to pull some of those targets about what do you even begin with if you're working with a 1-year-old or an 18-month-old. So that's what we'll cover over the next 2 hours. So looking at the diagnosis, I'm not sure what the numbers here in Greece are, but across Canada and the UK, the average age of diagnosis is still between 4 and 6 years of age. However, the most recent research is showing that symptoms can appear as early as 3 months, and 3 to 14 months we're seeing lots of them, with a diagnosis stable by 18 months. So if we can have a stable diagnosis by 18 months, but the average age is still 4 to 6 years old, what's happening in that gap? Why is there 2 to 3 years before diagnosis is happening? So there's a big bottleneck throughout North America, the UK, Australia, with early childcare medical providers first not being able to identify what the earliest signs are. Having kind of preconceived notions that autism emerges after 2 years of age, and not knowing what it would look like in a younger child. To reconcile that, the Center for Disease Control, which is kind of the oversight for the medical branch in North America, has mandated to do mandatory screening at every child wellness exam, so at 12 months, 18 months, 24 months. However, even with this mandatory screening, what they're finding is that pediatricians are not using the screening tools properly. And so a doctor may have the parent fill out the screening tool, and then they might not score it. They might score it incorrectly, or they may overrule the score with clinical judgment. So they might say, the screener says, you know, your infant has a lot of risk, but I wouldn't worry about it. You know, come back in 6 months and we'll reevaluate. And so what a study by Nadler et al. In 2015 found is that actually 75% of these screeners that were mandated were actually scored improperly, and they failed to actually screen these kids that were showing positive signs for autism. Oftentimes there's a misdiagnosis happening in those early years, so pediatricians or those first-line primary care practitioners, they might refer for a hearing test first, or they might refer to a SLP, or they often just say, wait and see. So they might be unaware that there's any treatment that is available prior to diagnosis, and if they don't feel comfortable diagnosing until 18 months or 2 years of age, they often just tell the parents, wait and see, come back in a few months, or come back at 2 and we'll reevaluate. So what wait and see looks like, and if you work in the early intervention field, you may experience this with parents where they had this inclination, you know, at 1 year of age that something wasn't right. They maybe saw the doctor by 18 months. The doctor said, you know, come back at 2. You know, at 2 they might have sent them for a hearing test. That came back negative. And then, you know, by 2.5 the doctor said, oh, okay, maybe we'll send you for a referral. And it might be 3.5, depending on wait list, before they're getting diagnosed, and 4 years old before they're starting treatment. And so we're going to learn over the next 2 hours of why we've wasted those most important years on wait lists, and what can happen if we can actually intervene at those first signs rather than waiting for that full onset of the diagnosis. So changing the perception of what early means and finding that early detection. Before, it used to be if we started with a child at 3 or 4, we thought, this is great, we're starting with them so early. In the UK, they released on the National Autistic Society. So it says children can be diagnosed as autistic when they're quite young, in some cases from the age of 2, but not everyone is diagnosed early in life. So they're kind of insinuating 2 might be the earliest that you'll see symptoms. The Center for Disease Control in the US said it can sometimes be detected at 18 months or younger, but at 2, it's the diagnosis by an experienced professional. It can be considered very reliable. So in the UK, they're still kind of sending out, maybe by 2, you might start to see signs. The US are saying by 2, it's actually stable. So we're looking at how can we even go back a few months prior to that and intervene sooner. So 2 of the big messages I want to get across today are that every month counts. So between the 1 and 2, the amount that you can get done every month is so imperative that we don't want to wait and see what happens. So we know ABA in the IBI, so early intensive behavior intervention, produced significant gains. So you're probably familiar with the low-VAS study from 1987, as well as that's been replicated many times that early intervention is effective at reducing autism symptoms and acquiring many alternative behaviors. With the majority of that research, it's been done with children 3 years and older. So we know early intensive behavior intervention is great for kids that are 3 and older. Where there's a gap in the research currently is what do we do with the children that are 18 months or 12 months to 3? What is the best practice for that age group? And that's still being determined, and the research is still emerging on that. 2 studies really looked at optimal outcomes. And so when we speak of optimal outcomes, it's that children are no longer meeting the criteria for ASD. So we're not saying they don't have it anymore, but if they were re-diagnosed, they no longer would meet the criteria. And so 2 studies really pointed to that the main predictor of reaching an optimal outcome, so no longer meeting criteria, was the age at which they started from. So McDonald et al. Out of the New England Center in the US, point to this one. So children that started early intervention between 18 and 23 months, 90% showed significant improvements in the first year, and only 8% of them showed very low improvements. Waiting just an extra 6 months, so between 2 and 2.5, 24 and 29 months, that number dropped to 70%. So now only 70% were showing significant outcomes in the first year. Going from 2.5 to 3, that number dropped significantly to 34%. So just when we start at 2.5, we think, great, that's still early. Only 30% of those were showing significant outcomes in that first year, and 66% were showing kind of low to no, not significant. And then between 3 and 4, it was down to 30%. So you can see by starting before the age of 2, that year between 12 and 24 months, the progress that you can make and the amount of kids that are positively responding to intervention is significantly higher than any other group, and it just drastically drops with every month that passes. So we'll argue that the most critical year is actually between 1 and 2, and I'll go into why it's not 0 to 12 months shortly. From birth to 3 years of age, that's the most transformative time of brain development in all of postnatal brain development. So from the time you're born, your first 3 years of life, you're creating the most neural pathways and the most neural connections. And then after 3, it actually begins to slow down. But what we want is a delay. Even though there's bottlenecks to receiving a diagnosis, there doesn't need to be a bottleneck to receiving intervention. So we don't need to have diagnosis only begin, or intervention only begin once diagnosis has occurred. So that's where pre-diagnostic intervention comes in. So we might not have the capability yet to diagnose at 12 months of age, but we are able to actually reliably see symptoms that are predictive of a later diagnosis. So how can we intervene at 12 months of age in order to ameliorate those symptoms so that by 18 months or 24 months, they're either not getting diagnosed or getting a much more milder form of a diagnosis? And why does that happen? So during that time, that transformative time, the neuroplasticity in the brain, so you'll hear neuroplasticity, also called neural plasticity or neural elasticity. And that's the time, or what that refers to in the brain is when neural connections, they're being created, so they're rapidly growing. They're being organized, so we're a filing system of how we use the information we're collected. And then they're being pruned, so neural connections that we've made that we don't use get cut out, and so we're always pruning our neural connections so that we can make the most efficient use of our brain. We know that neural connections are shaped by experience with the environment. So the more enriched our environment are, the more interactive we are with our environment, the more neural connections that we're making. And that it's even maximized further by that self-generated experience. So it's not enough to be in an enriched environment where things are happening around me, but I'm not engaging with it. That self-generated and participation in that environment creates much more neural connections. So we want to increase that participation during that time, from 0 to 3 years of age, rather than just that kind of exposure to it without that participation. So if you think of the neural connections or synaptic density as like the roadmap in your brain. So every few months it's doubling with more roads and more roads and more roads, and those are the connections that are being formed. So in infancy, so a newborn is born with fairly sparse neural connections. So there's just a few. By 1 month, you see them increase greater. By 6 months, it's becoming much more dense. And by 2 years, it's kind of already a chaotic roadmap. And so we're looking at the ideal time to start treatment is while those connections are being formed. So if you think of it like a city planner and building highways, and you want to plan a city, the best time to plan a city is before the roads are being built, rather than have everything built and now try and accommodate everything around and organize around that. So the intervention, so providing that intervention, early intervention, it's going to be maximized when those brain connections are being established. So we're working from kind of building the foundation from the ground up, rather than trying to change a typical circuitry that's already formed. So you may, working with some of the clients that you do, you may realize that it can be more difficult to change behavior that's already established in a bad habit rather than shaping novel behavior and starting with a new behavior. There's a great example of this in the US. There's a large health company, and they kept acquiring new ABA clinics. So they were buying out all these ABA clinics so that they could own a ton of different clinics. And what they found is they would go in and try and change a clinic and change the structure in there. And it was so difficult to change the culture. And these are experts in behavior going in and finding it difficult to change the organizational behavior, that they actually stopped acquiring new clinics and just started to build new clinics from the ground up, because that was easier for them to create the exact organization they wanted. So that's kind of the same idea with the brain, right? Rather than trying to change circuitry that's already formed, being there from the time that it's forming. Looking at how much of a difference of interacting with your environment is, there was a study by Nelson et al. in 2007 that looked at foster children in Bucharest, Romania. And so the study examined outcomes of infants that were reared in this kind of impoverished orphanage. And they compared infants that were placed into foster care by 18 months and those that weren't placed into foster care until 30 months. And so that was kind of a random selection of how the infants were placed. And so they considered the orphanage to be low stimulation. So there wasn't a lot in the orphanage. There wasn't a lot of resources with toys or human resources for interaction, where once they went into foster care, it was assumed that they had a bit more of an enriched environment. What they found with developmental quotient, so similar to IQ but for infants, is that those children that went to foster care had a 14-point higher IQ or development quotient than those that were 16 months behind them going into foster care. So that intervention to be able to start and give that enriched environment when they're early really does have an impact on future cognitive development as well. And that's only possible if early screeners and assessments are used and used correctly so that we can see those red flags and begin that intervention at the first sign of those symptoms. So what screeners are available? Feel free to take pictures of this. I'm not going to go into detail about each screener, but just giving an overview of what's available. Many of these are available free online. So there's something called level 1 screeners, and these are made more just for the general population, designed to be applied at a doctor's visit or daycare center. They're often usually pretty quick checklists and more of a broadband, so they're not necessarily great at picking ASD out from developmental disabilities or other delays, but they're able to kind of flag something's happening with development and kind of refer for further screening. Further to that is more specific level 2 screeners that more specifically can identify ASD. So a very popular one that's great, it's used at lots of hospitals across North America, is called the MCHAT, or the Modified Checklist for Autism in Toddlers. And the RF is the revised with follow-up. So that if they're getting kind of in that risk zone, they're not quite high risk, but more moderate risk, there's a follow-up questionnaire to decide if they should be in the high risk or if it's to move them back to the low risk. There's a screener called the AOC, so you need specialized training for this, and it's a semi-structured infant assessment, good for infants 6 to 18 months of age. So I've been trained and certified on this, and I'll show some video of what an infant assessment will look like. Then there's the STAT that's designed to screen for autism in children about 24 months, but one study looks at using it even earlier at 12 months of age, and that's a 20-minute, similar semi-structured assessment. Another checklist, the POEMs by Maurice Feldman out of Canada, as well as another autism detection in early childhood. So these are just a small sample of what's available. There was a recent literature review looking at all the screeners, and they looked at 99 different screeners. So it seems that almost every university these days, or there's so many screeners up and coming. So what we need is kind of maybe fewer screeners and doing more research with the ones that we have to see which ones are the best. The screeners come from researching early signs, but trying to figure out what are the early signs can be quite difficult. So when looking at early signs, there's a reliance on parent report. So going back to parents that now have a child with autism, talking to them of, what did you first notice? What was the first signs like? And getting some retroactive feedback from there. Other difficulties what they're finding is that the onset of symptoms are less homogeneous than they thought. So each child is actually getting kind of a different presentation of symptoms. It's not each infant is, not using gestures and engaging in motor stereotypy. It's a kind of a different selection, just probably like the population of ASD in the spectrum that you've seen, is that each client's displaying quite a variety of different excesses and deficits of behavior, and therefore in infants and in the presentation it's quite similar, so it's hard to identify what those key symptoms are. Repetitive behavior, so that's something that more often comes in after 18 months, and it's not as common in children less than 18 months. So that's something that would be more visible. You could see a child engaging in repetitive behavior, but it's not necessarily a reliable early marker, and it's not seen that often amongst the population before 18 months of age. So how they research the earliest signs, so there's retroactive, and that's kind of what I spoke to about the parents. So looking at, what did they first notice, and going, having them recall. So retroactive research was great to kind of get early signs established, but it's definitely prone to a lot of bias, so a bit of confirmation bias and recall bias of what the parent actually remembers. After retrospective studies, they started to use home video review. So there's a great study in the mid-90s by Osterling and Dawson, And what they looked at is children that now had autism, that had the diagnosis, they looked at what kind of videotapes do they have available that they could go back and score. And almost everyone had their first year birthday party recorded on tape. And so they looked at first birthday party home video analysis, and they compared 11 children with autism versus 11 typically developing children. So it was a way they could go back in time and score what was happening to see were there differences at one that they just didn't catch. And what they found is that 10 out of the 11 children that did go on to get autism showed atypical development with pointing, with showing each other, with showing objects, with looking when their name was called, and with looking at people. So the symptoms were there, even when parents did not have concerns at one. By going back to the video, they did see them. So the children that later went on to get autism didn't spend as much time looking at other children compared to even children with intellectual disabilities. So it even differentiated intellectual disabilities from ASD by 1 year of age. With home video review, so that again kind of brought the field forward of what early signs look like. But again, it's a very small sample bias too. So you might take out the video when your child's doing something great and film it, and then they might start to engage in troubled behavior, and so you might put the video away and not keep recording. So it gives you some insight of what was happening, but it's still, they looked at how they could further improve that. So most studies that you'll see now looking at early research are what they call prospective studies. And that means is they're going to grab a large cohort of children from time of birth, and then maybe every 3 months they're going to take measurements on different skills or different assessments. And then as those children either go on to develop ASD or don't, they have those live captured in the moment prospective analysis of when those symptoms actually emerged. So a few notable prospective studies. So there's a big one that's been going on in Canada for about the last 20 years called the Canadian Infant Study by Lonnie Zwagenbaum. So you'll see his name up here often. He's a big Canadian researcher with infants and one of the people that inspired me to go into this field. And so rather than just getting a large cohort of all infants, where the rate of ASD is maybe 1 in 66 or 1 in 58 that would later go on, is they're more strategic with their sample and they look for infant siblings. So an infant that already has a sibling on the spectrum has a 20% chance of getting that diagnosis due to genetic factors. So they get a large sample of what they call high-risk infants, meaning that they've got a sibling already on the spectrum. So if you have 100 infants in your study, 20 of those are likely to go on to get the diagnosis if they're high-risk infants, compared to if you just used a general population sample, you might have 1 to 2 out of that 100, right? So it's a bit more strategic with your sample for research. And what they found was using prospective analysis that between 12 and 18 months is where they really started to see atypical patterns of visual tracking, and we'll look at what that is. Social orienting, so looking to see how your mom feels about that loud sound, or is she excited that there's an airplane in the sky. Joint attention, different forms of imitation, so motor imitation and vocal imitation. Affect regulation, decreased flexibility, the frequency of babbling and range of babbling. And motor skills was found to start to differentiate as early as 6 months. So delays in motor have been consistently seen to be an early indicator of later ASD. In 2015, Zwagenbaum published a great literature review updating all the earliest signs research. So up until 2015, or the end of actually 2013, it was 2015 by the time it was published. And then with this group, so it wasn't a systematic literature review, but he did rally a ton of prominent researchers in the field, from Amy Weatherby and Connie Cassaray, and people that have really established this field. They all kind of reviewed all the literature and put forth a bunch of statements of what the early indications are. From there, part of my PhD research, we looked at what the gap was from this study to what we know now about early signs. So I've continued this on with putting forth a systematic literature review to look at what are the earliest signs that we've seen now in the last 5 years, looking at prospective studies only, so just the ones that are measured kind of in real time, not recall or not home video. We conducted it using a systematic literature review. And one thing that I did that was different than the previous review is I looked at only where the high-risk infants with autism actually differentiate from the high-risk infants that do not go on to get autism. So we talked about that sample with 100 infants that have a sibling on the spectrum. And 20 will likely get autism and 80 won't. A lot of the early signs research looks at that entire high-risk population together and talks about what are those high-risk symptoms. Where I really differentiated what are the ones that are unique only to the children that actually go on to receive a confirmed diagnosis. And so I'll talk about a lot of my findings reiterated what Zwagenbaum found. What you'll see here is quite a common overview that I've put together of how the symptoms play out. So with motor development, so low anticipatory response, so say playing peekaboo. So typical development, a child's going to be really excited to try and knock down the curtain or see who's behind the curtain. So that low anticipation response that they saw. Less object exploration. So if it's a new object, just exploring it, not the same, not rotating it the same amount of times or manipulating it the same way. Difficulties with different motor tasks, so different reaching and grasping, and how the kind of different types of grasps that they're using. Head lag, so pulling a child that's 6 months kind of up to sitting. If their head was lagging, that was found to be a big predictor of ASD, and that's one of those delays in motor control that they were looking at. It was looked at vocalizations, just the rate kids were babbling, and as well as the range. Repetitive behavior, so just a few studies looking at that repetitive behavior before 18 months, or even in the first year. So it wasn't, there was not a ton of research that found many children engaging in that behavior. Most of the research, as you can see, is done in the social communication realm, so around joint attention and social smiling and eye contact, using gestures, using facial gaze. So kind of all those pre-vocalization skills as well. So being able to follow a point, being able to use a point, being able to smile when someone smiles back at you. So those were all seen to children that went on to get autism engaged in these behaviors less. And some temperament. So early reactive temperament, so either overly sensitive, either hypersensitive or hyposensitive. So a big textbook could fall behind and the child might not react at all. Or a small tap could happen and they might have a big startle. So kind of those atypical reactions in temperament we're seeing. That's kind of an overview of some of the early signs. From the systematic review that I did, one thing that was notable that has not been captured in the other reviews or the other literature reviews is the idea of using regression as an early symptom. And so Ozenhoff, I believe it's, Sally Ozenhoff, what they found is that regression in infants, it was believed to be not as frequent a regression onset of ASD. And what that means is the loss of skills, so that the child's developing appropriately and then they hit 18 months or 12 months and they've lost some of those skills that they previously had. So that was believed to be a bit more rare. But what she did is she looked at how are we actually measuring the loss of skill. So if we're asking retrospectively, you know, has your child lost any skills? Parents were likely to say, no, not really. But if it was measured prospectively and using a dimensional scale. So every 3 months, how much is your child looking at you? How much is your child smiling? How much are they using gestures? 3 months later, measuring the exact same skills, and 3 months later, measuring the exact same skills. So capturing what's happening in the moment and then comparing it, what they found is that regression was actually much higher than they believed. So parents reported that it was only happening about 29% of the time when it was done retrospectively and using categorical, so has your child lost skills, yes or no? When they changed how they looked at it, they found 66% of the parents then found their child to have lost skills. And then when that was actually looked at by a clinician, they found 88% of the sample actually showed regressive onset. So they had lost the skills just by changing the way that it was measured. So this has huge implications for creating better screeners. So a lot of times the screeners are just one point in time. What's your child currently doing? Do they point? Do they follow a point? Do they smile at you? Do they show you things? And then you score that up and you see what's happened. But taking this into account, measuring the same skills a few times and looking at, are you scoring them less? Are they scoring less in smiling? Are they scoring less in gestures? And seeing if that regression is happening, because it was only happening in that high-risk ASD population. So only the children that went on to get autism actually showed a loss of skills. The high-risk kids that did not get a confirmed diagnosis of autism did not show any regression. So it was really a unique symptom to only the kids that later went on to get autism. I'll show you here, so some of the children I worked with. So these are some of what it might look like. This boy's 12 months old. And so we'll look at the deficits in eye contact. I don't know how well you can see it there. So you can see there the child doing pretty much anything to avoid eye contact, and at the end when he really couldn't turn anymore, he actually just closed his eyes. He's responding to name. And responding to name across parent report, it was something that was very common, and even across my sample, one thing that parents really started to feel alarmed about is that their child was not responding, not only to their name, but more to voice as well. And then this boy did engage in repetitive behaviors at 12 months. So his mom will say, yeah, he always does that. And so any object he'd pick up, rather than exploring it with his hand, he would just tap it against his head there. So those are 3 of the earlier signs. From the actual assessment, from looking at how we're testing, disengagement of intention was found to be predictive of later ASD. And so what that looks like is, how well can a child disengage from something that they're looking at to explore what's happening over here? So if they're engaged in something and their name's called, that would be a form of disengaging, to just see like, what's happening? Okay, it's not important, I can go back. And so you'll see how it's tested here. I do both the visual tracking, so how well the child can follow a preferred stimulus without kind of their eyes deviating for it as it crosses midline, as well as you'll see the disengagement from attention here. You can see pretty fluid visual tracking there. You can see how quickly she turned to explore what that sound was. So it can show she can very much disengage, check out what's happening, and maybe go back to what she's interested in. As well as she's trying to engage with me there. So when you look at all those early signs that I presented, so if we look at, so what are the early signs? Is the takeaway point is there is no one single sign that you're going to be like, okay, that sign on its own is predictive. We're really looking at a collective amount of signs and reaching that threshold. With early signs, again, it's not necessarily something like repetitive behavior that it's going to be obvious to see, which would be like an excess of behavior. What you'll see more is that deficit in behavior. So less social smiling, less eye contact, less gestures, but that doesn't mean none. And so what can be really difficult is if typical development, maybe a child looks at people 60% of the time, where high-risk children that later go on to get autism might look at people 30% of the time. So they're still engaging in that behavior, and so to try and find that symptom live is probably just impossible for parents. It might be a bit of a feel, like I don't feel they look at me much, but you know, then there might be some times where they really are, and then they're like, oh, I feel it's happening. So really seeing that difference in frequency of the symptom, so just more deficits in doing behavior less, and that makes it really difficult to see these early signs. And so that's why different screeners and assessment tools should be used. That clinical judgment on its own and a 10-minute doctor visit is not going to be enough to fully capture it. Where the standard screeners and assessments have done a good job to figure out if there is enough there for further referral to warrant follow-up action. So if there is, and the child's screening positive that there's enough symptoms there, what can we do? So they're, you know, at 12 months, they're showing that yes, they are showing high risk for ASD. They're showing positive scores on a lot of these screeners, but no one will diagnose them for another 6 months or 12 months. So now what can we do? So that's where pre-diagnostic intervention comes in. Let's intervene before we're ready to diagnose, and maybe we can actually get in while that brain is still forming and really alleviate some of the symptoms rather than letting them manifest further. So some great key contributors and pioneers in this field, Sally Rogers and Jessica Bryan and Connie Cassaray have all been working with infants for a long time. Sally Rogers published a paper in 2014. It was a pilot study with 7 infants from 7 months to 14 months of age. And by starting with that young through a 12-week parent training, what she found is that by 3 years of age, 6 of the 7 no longer met criteria for ASD. And there was kind of a quasi-experimental control group. So there was 4 infants that declined the treatment, and all 4 of them did go on to get the diagnosis. So what they're finding is they're able to catch these children up by 3 years of age and reduce a lot of the symptoms and the delays that they're showing by intervening so early and while that brain plasticity is at that perfect time to intervene. At the same time, and why 1 is probably better than starting at birth, is 12 months is greatly timed perfectly with that explosion of other skills. So now they're beginning to walk. They've got bilateral coordination, so they can imitate different things and they can use their hands more. They've got more hand control. And so that really facilitates that child being interactive with their environment. That boy that you saw, he first came to me when he was 5 months old. And it's amazing that you could see the signs that young. It's just that refusal to make eye contact. But there was not as much you could do to really build those skills. You could do some things with eye contact, but you know, there was not a lot of imitation, especially if he's got delayed motor skills. He wasn't crawling, he wasn't walking. So really by 12 months, they've got a lot more mobility, and you've got a lot more options of how to really work on that interactive with the environment. And with all those models that I showed you, and as well with my model, we all use parent-mediated intervention. So we had parents being the therapists. Parents were in charge of all the changes that you see happening. And so why parent-mediated intervention? So 1, it's cost-effective. There's not a lot of funding, especially if children don't have a diagnosis. If they don't get to be part of a study, I don't know of any place that's funding pre-diagnostic intervention as of yet. So parents might be just logistically a great option, is that it's someone that's free to train. It's also developmentally appropriate for an infant at 12 months of age to be spending that time with the caregiver. So when we looked at early intensive behavior intervention in the Belfast study, anywhere from 25 to 40 hours a week were spent with a therapist. For a 1-year-old, that wouldn't be developmentally appropriate. It would be difficult, on the parent likely and on the child. For that age, learning occurs through daily interactions. Every interaction. Learning occurs during mealtime and bath time and bedtime, and those songs during diaper changes. And so those are the times we want to be capturing to include all those learning. It's not appropriate to have, a 12-month do flashcards at a table, right? So how they're learning is those daily skills. So we do bath time and we do body parts, and teaching the parents how to kind of maximize that play. And then lastly, why parents are kind of the best therapists at this time is there's a transactional model that occurs. And so what that means is that as the child begins to develop atypically, a parent might start to respond atypically to their development. And so it actually starts to reinforce this cycle. So if you think of defective manding, so it's okay for a 6-month-old to cry when they're hungry, and mom knows what that is. But at 12 months and at 13 months and 14 months, if that's still their method, and the parents are just like, okay, when he does that, I know what it is, and they continue to reinforce this cycle. Or every time I sing, he runs away, so I'm going to stop singing because he doesn't seem to enjoy it, right? And so what can be happening is just reinforcing a lot more of these deficits rather than eliminating that barrier. So if we can improve that quality of that didactic interaction, we're then removing that barrier towards typical development. The parent's no longer kind of standing in that way of typical development. And I'll show you what that looks like here. So here's during baseline with one of the participants. So during baseline, the parents are just instructed, play with your child. So it's difficult to see. She's narrating a little bit. But based on kind of her body position, how the toys are set up, how the environment's set up, it's pretty difficult for her to engage with her child if her child's not interactively engaging with her. So then with a few tweaks on just body position and controlling the material, so this is about 6 sessions later, you can see how much more in control she is of the interaction. So she becomes okay taking the toy back in order to present it again. She's positioned herself so that eye contact and social referencing can occur, compared to when she's behind him, the child has to turn way around to engage. It's always hard to video because the kids are so attracted to a phone. So you can see there, by just controlling the material, she's forcing a bit more communication, interactions, and opportunities. And so with that kind of standing behind and maybe vocalizing less and not maybe attempting eye contact, how that happens is our behavior is shaped so quickly from children, from any experience. So if you think of holding, you know, a 6-month-old baby and you make a funny face and that baby laughs, what are you likely to do? Probably make that face again. If you make a face and they don't respond or they get scared, you're probably likely to not make that face again. So really within 1 to 2 seconds, that baby's shaped what we're going to do next. And so if you think of these parents where day in and day out, you know, they're looking and they're trying to play with their child and their child's always going, what happens to some of them is they just start to do that a bit less because they've never been reinforced for it. And so that's the transactional cycle that we want to break by retraining how do we actually teach engagement, how do we kind of control the environment or set up the environment a little more so that these interactions can happen. I'm going to play you through, it's about an 8-minute long video, but what you'll see here is the time, it's 12 sessions of parent coaching done throughout 6 weeks. So what you're going to see is what 6 weeks of development can actually look like. This was the first participant in my study. And the mom, you'll see, she's fantastic. She's highly motivated. It was their only child, so she had the time. She ended up leaving her job so she could work fully with the child. But I'll allow this to play fully through so that when I kind of allude to different targets or lessons that I teach throughout, you've kind of seen a parent run kind of everything. So you can get comfortable. It's a bit longer of a video. These are just baseline that you've seen already. He came over to explore the sound, but he never once looks up to say like, oh look what I'm doing. There's no shared experience in it. He's exploring it pretty on his own. Back to the top. Out of all 10 participants, he was the only one that did engage in the repetitive behavior. That was obvious enough that we saw it multiple times. This is the first session. So even though you can't hear the sound, the parents aren't vocalizing much. So they're not narrating what he's doing. And then when he does reference, he's just kind of directed to look back. Session 5.
1, 2, 3.
see already how much more he's looking at mom, how she's been able to like capture his attention and position herself in a way that he can make eye contact with her. This is session 7. Mom's doing great. She's following his lead. As he moves to different toys, she's not trying to get his attention back. She's going where his interest is. See how great she is at just creating a new learning opportunity. Rather than just giving it back, she just picks up something else and makes them do a choice, right? So forcing that communication. We worked on imitation by there. Even things like that, turning the page halfway so he's got to engage and turn it fully. Look at the look there. So it popped, and he does. There's another instructor in there, but he looks and like, hey, did you see that? So that joint attention. You see the mom continuing walking around, so she's always in a good position for him. Providing so many opportunities for him to learn. So there's imitation or following just instructions or communicating. So this was a few months after the sessions ended. So all that change that you saw happen actually happened in about 2 months' time, with the mom coming in twice a week for an hour each time. So with 2 hours of essentially intervention and training the parent, we were able to see pretty significant changes happening. And so as our services are so exhausted and it's hard to provide so many hours of therapy, parent models can be something that can be underexplored, or when they are good candidates, you can see kind of amazing results from them. So looking at early treatment options, so what currently exists for early treatment. So there's been a movement called NDBI. I'm not sure if you're familiar with it, but it stands for Naturalistic Developmental Behavior Interventions. So the Early Start Denver model, the Jasper model, and pivotal response training. And so it's a more naturalistic approach to ABA, or early intensive behavior intervention, that uses more naturally occurring reinforcers. So if you're making the car go down a ramp and the child imitates you, then maybe you crash the cars, or you do something that's reinforcing with the cars rather than reinforcing it with kind of an arbitrary edible. So it's using naturally occurring play environments, much like you saw in the video, and kind of moving more with the child flow, capturing their motivation. So that's more of a naturalistic model. The pre-diagnostic models that are out there right now, two of them that are only available for kind of research purposes only, or with a lot of certification out of certain clinics. The social ABCs is out of Toronto and Halifax, and Infant Start is kind of a continuation of the Early Start Denver model by Sally Rogers and Laurie Vismara, that's out of UC, I don't know if it's UCLA or UC Davis Mind Institute. And so when I was preparing this research and trying to figure out what currently exists in the literature, what are the targets we should be teaching these children, what curriculums exist, what I found is that there started to be this influx of publications around the topic, but every publication I read, there was very little information about what are you actually teaching, what's the curriculum look like, what is the content of your treatment program. And so one thing that I became very passionate about is I believe research should be for that purpose of disseminating information, and that you as clinicians should be able to pick up a research article and learn something from it that you can apply, and that's how we're going to get that information out there. And with a lot of the previous models, what I saw is that it was showing effectiveness for their model, but without doing additional certification that was, offered infrequently, if ever, or just out of their clinics. You weren't able to actually learn these skills. And so a big part of my PhD was creating this curriculum and creating kind of step-by-step of what I'm doing in each session, so that someone else can just read it and be able to implement it without needing additional certification, especially if you are pursuing your BCBA or BCABA, and you have that behavioral background. I'm trying to make it as user-friendly as possible so that you don't need additional certification. Yes, it's recommended to be overseen by that, but with such time-sensitive nature of this, what we learned is that every month counts. And so if you have concerns with your child and they're 14 months of age, and you're trying to go to the literature to see what happens, and then you're like, okay, well, I need to take this course, but it's offered 3 months from now, then by the time, it could be 6 months later, and what's happened during that 6 months, right? And so I wanted to be able to create something that's open access and available so that people at least have some tools. This is one of my favorite quotes. I'm not sure if you know Elon Musk, the inventor of Tesla and SpaceX. There's a political show in the US called Stephen Colbert, and he was on the Colbert Show, and this was right after he launched Tesla, and Colbert was like, so you've made all your patents for Tesla available to everyone. Why are you giving away the store like that? And Elon's response was, if we're all on a ship together, and there's holes in the ship, and we're bailing the water out, and we have a great design for a bucket, we should probably share that design for the bucket. And that's where I feel we're at the exact same spot with autism treatment, is that the rate of diagnosis continues to increase. Our services are rapidly exhausted everywhere. I don't know of a single place where there's too many BCBAs or too many providers. Everywhere I look, it's exhausted. And so the more that we can share what works, and the more kids we can reach, we're in no shortage of clients. And so that's kind of where I'm coming from, of how can we get this information out there so that it can be further researched and further developed and further improved. And so I've called my 12-session curriculum the SPARC, which stands for the Sequential Parent Curriculum. And the ABA foundations that are used with it, so we use behavior skills training with in vivo practice. So behavior skills training, so every session that the parents would come in, we're using a behavior skills framework. So that includes, first I'd give an instruction, a little theory behind why we're teaching, what we're teaching, and how we're going to do it. The next step of behavior skills training is modeling. So then I would model what this looks like with their child. Then they get a chance to practice, so that's the rehearsal. So they get practice with their child, and then there's feedback given. And by using it in their homes and with their actual child, that's that in vivo practice where they're actually getting, or in situ practice, real life experience, right? And that's the most evidence-based for a teaching procedure, where you'll see some other teaching programs or early intervention programs that it might be all didactic lecture for the parents. So there's, I think it's More Than Words is a prominent SLP one. And if you get up to 10 sessions, only one you bring your child to. So it's very like instructional based. What we found is that it was the parents actually like jumping in there with their child, trying something, and then us being able to troubleshoot what worked, what didn't work, and being able to practice it and improve it right there, rather than just learning from instruction. So that's a big part of the procedure. I based the framework on the elements of verbal behavior, so really focusing on the function of the language. So a child using gestures to request, not just using gestures for the sake of using gestures. So we really looked at how can they mand for help, so contriving opportunities where the child needs to get something. So we put their preferred item in a bin that they can't open, and we do a lesson just on handing the item to the adult for help. And so that works on that request for help. So teaching parents about establishing operations, so that's satiation and deprivation. So if the child's got unlimited access to their most preferred things, they're going to be very difficult to engage with because they're going to satiate on them. So getting the parents to kind of create more control over those preferred items. Antecedent manipulation, so setting up the environment for creating lots of learning opportunities for the parents to be constantly moving around, so we're maximizing the amount of learning opportunities that can happen. And then training for generalization. So one of my favorite ABA articles is by Stokes and Bear from 1977, and they provide 10 technologies on how do you actually program for generalization. Like we work on so much of acquisition, how are we building generalization into the programs? And so I took a lot of these and made sure that they were just part of how we teach from the beginning. So using least to most prompting, using natural maintaining contingencies, so in that natural environment, using lots of different examples. So we're not just going to teach one example of imitation, we're going to teach 10 different ones. Training loosely, so varying SDs, so teaching the parents more the broad description of what you're doing, but not a specific instruction, so that the child's already getting used to varied SDs. And then programming common stimuli. So these are all found to help improve generalization, and so they were built right into each lesson. So as you saw, I think Katerina had mentioned it, although it was in Greek, so I'm not sure. But we have submitted this currently to the European Journal of ABA, and so hopefully it will be published shortly. So there'll be a further description in there, but feel free to take pictures of this, and I'll go through quickly each of the lessons and what we worked on. So the first two sessions were just baseline, so taking, the parents were just taught or just told to play with your child. Session 3, we worked on, I'll look up here. Teaching the parent pairing again, so first looking at what is their child interested in, so almost a free operant preference assessment. So just sitting back and observing your child of where their interest is. So they're going to their cars, okay, so cars is probably a preferred item, and watching where they go. What happened very often in baseline is that observation piece wasn't happening. So the parent was always trying to get the child to come to them. So the child was busy playing with cars and the parent's like, come see this, come see this. So kind of reframing that of where is their interest, what are they currently interested in? And then their first assignment for the week was find 5 new things that your child likes. So that was really that pairing piece and conditioning. And parents got very creative. They went to the dollar store, one got a feather duster and they had a tickling game. But just really looking into what's motivating your child and where their interests are, what makes your child smile. So finding that smile, finding that laugh, because that's going to be our most powerful reinforcer for teaching later and building up that repertoire. Then providing kind of a narrative of what the child's doing. So tacting what the child's doing or what you're doing. So providing functional language to the play. So it's not just quiet, we're teaching those words or we're pairing sounds with it. We're teaching children to follow the child's lead and move with the child. And optimal body position. So always being across from the child and at eye level, so that any chance the child looks at you, you're able to quickly reinforce it with, a big smile or excited voice. If you're behind them, there's, very little chance for that eye contact to happen. Then we worked on antecedent intervention, so controlling the materials, so how to set up the room. And this worked really well when I did sessions in the home versus in the clinic, because we could actually look at what's their living room set up like, and work with what we have. So using shelves, using bins. Once from there, we know what they like, then we can work on them requesting for help, demanding for help by putting those items out of reach or needing help to access them. Then working on making a choice between 2 items, so knowing one that they like and then one that they don't like, so they scan and select the one that they do, and fading that back to an actual point. Teaching imitation and echoic, so providing lots of opportunities for the child to imitate and interesting things for them to imitate. If vocal imitation emerged, we could work on echoic to man transfers or imitation to man transfers by teaching sign language. Now that they've got lots of different skills, how do we intersperse those skills naturally across play so we're not just drilling the child with imitation for 20 minutes? We work on any individual goals or anything that the parent was struggling with that their child didn't achieve. And then how do we take all those things that we learned and apply them to your daily routine? So diaper changes and dressing and bath time and feeding. I'll show you some meal time shortly. And then at 1 month follow-up, we would administer the screening tools again and a maintenance and booster session. So anything not working, anything they have questions with. And then similar at 3 months, and then any recommendations or referrals for further treatment. So I'll show you the data of what that looks like. So we looked at, can pre-diagnostic, parent-mediated early intervention improve autism symptoms in infants? So we used a concurrent multiple baseline across participants. This was done across 3 actual studies. So there's a pilot study, phase A, which had that first participant that you saw, 4 participants after that were done at the clinic, and then 5 participants at home that were part of the main study, with small changes made each of the way. I won't go into those small changes because it was relatively kind of the same intervention across all 10. The screening tools included the Mullen, the infant toddler checklist, the AOC, the MCHAT, and the ABAS. To be included, the parents had to be home 50% of the child's waking time. So they needed to have one parent that was at least home with the child to be part of it. Otherwise, if they were in daycare or with a grandparent or a nanny, they wouldn't have that time to practice. How they were referred to me was through a developmental pediatrician that flagged them as high risk, flagged them as symptoms, but was not confident to diagnose them based on their age at that time. So then they were referred to my study. We did the screeners, and if they were positive on all those screeners, then they were admitted into the study. 8 of the 9 parents reported concerns between 5 and 12 months. There was one parent that their child was an infant sibling, so their other child I was actually working with early intervention and had a confirmed diagnosis. And she knew I was doing this study and she was interested in it, but she wasn't actually concerned with her child's development. after doing the screenings, the child scored positively, and it was showing that there was red flags on there. So it was a bit different of how she was admitted in. And I think that really affects the motivation with going forward with parent training. So the parents that really felt concerns and maybe saw 3 doctors before they found someone that knew something that could refer them to a treatment compared to one that actually didn't have concerns. Something to consider with how effective they're going to be administering that intervention throughout the week. How big of a priority is it to work on those skills if they're concerned about them versus not concerned. What the parents mostly reported was difficult and distress. So as you saw with that little boy, a lot of crying, a lot of easy to be distressed. Low affect, so not as much happy, smiling, social smiling, not attending to voice, some stereotypy covering ears, banging toys to head, and then a lack of eye contact. So all were done with 12 sessions of parent coaching. The very first one, it was done over a 6-week period, because the parents were leaving kind of in 8 weeks, so we had a more condensed period, and the rest were done over 12 weeks. IOA was taken and fidelity of intervention, and then screeners were taken both pre and post, as well as a social validity questionnaire. So something that you'll see, or that's probably not seen enough in ABA research, is a social validity measure. So we know this treatment works, but how likable is it? How much are consumers satisfied by it? Is it easy to use? Is it cost effective? Do people want to do this intervention? And that's really important as we're trying to change the perception of ABA to make sure we're providing treatments that people actually like to do, or that that are meaningful for them. So we looked at both their change in scores from pre and post, as well as some continuous measures of how many learning opportunities the parents were presenting, as well as the child's eye contact and how many learning opportunities they were responding to. Intervention sessions were set up using that behavior skills training. They would first start with any follow-up questions from the previous session. So what was working, what wasn't working, do you want me to clarify anything? Then we'd film a 5-minute video of them demonstrating competency in that skill. Then I'd introduce a new topic for the next session. I would give the rationale of why we're teaching it, model it, have them practice it, provide feedback, and then we would set the goal for the following session. So something like find 5 new things at your child that makes them smile. And so you might be thinking, with something like this, in 12 weeks, from an 8-month-old to 11-month-old, one of the biggest confounding variables or threats to internal validity would be just maturation. So children are going to develop and they're going to gain skills automatically, right, especially during this time. And so what we want to look at is what would be expected to be gained, and then what's above and beyond. And so we can look at what's happening in other research for this, as well as looking at some of those standardized assessments. So the Mullen gives an age equivalent score of what age equivalent they're at, and then when we follow up where they're at after it. And so it's in months, and so if they're at 5 months or 5 months level at the beginning, and then 3 months later they're at a 15-month level, they've gained 10 months in essentially those 3 months or those 4 months. And so we know that's above and beyond what's expected. So 1 month on the assessment for every 1 month that's passed would be what's expected of natural development. And so in the Mullen here, the first one's the raw score, and then the second one's the age equivalent month. So this child on the receptive language went from 3 months, so she was 6 months of age, or 16 months of age at intake, 20 months of age when it finished. Her score, she went from 3 months an age equivalent to 25 months. So she gained 22 months of development within a 4-month period. And then with expressive scores, very similar. So went from 2 months to 27 months. So that's an extra 2 years of development that was happening within those few months period. So that's how we know they're not just changing because time's passed. They're well exceeding. Now they're starting from quite delayed, like they're starting from a 3-month mark when she's at 16 months. But for this child, so she ended up past what was expected. So she was at 20 months, but she was performing receptively and expressively of a 25 or 27-month-old. So you can see that all throughout. So this child started at 4 months and ended up at 10 months. So less dramatic, but still 6 months of development in a 4-month period. We went from 5 months to 19 months during a period of 13 to 17 months. And improvements on all the other scores as well. So the MCHAT here, so a score between 3 and under means that there's no risk. 3 to 8 means that there's moderate risk and they need to do a further follow-up. And then above 8 is a high-risk score where you're supposed to just be referred to for an assessment. And so a lot of the children, actually everyone except Anne, had a very high-risk scores. So anything above 8, and it's out of 20, was high risk. And then in the post, those all dropped significantly more to moderate risk. So there was still, it wasn't that they were completely all in the clear, but a lot of the autism symptoms had greatly decreased. So this is the child behavior. So we're looking at how often the child's looking at the parent, making eye contact, as well as how many learning opportunities they're responding to. And so it was measured using partial interval recording of 5 seconds, I believe. No, sorry, of 10 seconds. And so what you see here is very low levels of both eye contact and responding to those learning opportunities during baseline. Steady increases across all children that did well to maintain even at the follow-up. What I find that's not captured within the learning opportunities is that quality of learning opportunities. So what you see at the beginning is that the child might just give an item or they might respond to their name. So it's kind of a very, it's not as difficult compared to at the end, the child might be imitating, they might be using spoken language. So they would be scored the same as a learning opportunity, but I think the quality of what's changed is missed a bit. The changes in parent target behaviors. So we've looked at eye contact, vocalizations, and learning opportunities. So this one was from the pilot study here. So some of the significant ones, like some parents that you saw, they were making eye contact 100% of the intervals, where some went from 58% of the intervals to 85%, or this mom, only 30% of the intervals, increased the eye contact to 80%, 38% to 100%. So we're getting the parents to at least look at their child more, to vocalize more. So this parent, they were only vocalizing in 20% of the intervals, and by the end of treatment, vocalizing in 100% of the intervals. And then providing learning opportunities. So this mom too, going from 12% of the intervals of learning opportunities to almost 80%. So creating a lot more things that the child can respond to is creating that enriched environment, and it's creating that active participation for that child. I'll show you a few more outcomes, just pre and post. This one, as you see a lot, like the parents trying lots of different ways to engage, but just struggling to find those really motivating pieces of where the child's interest is. So whatever the child's holding is what they're interested in. And so the parent's doing a lot of things, but it's struggling to capture that child's interest. So as far as social validity, so we asked how easy was the intervention to implement. And so 5 would be very easy or strongly agree, and 1 be very difficult or not agree. The only 3 that we saw across all of the children, and that was just kind of neither agree or disagree. So this mom, she was a single mom with 2 children, like one that was confirmed on the spectrum and then another that was showing signs. And so even during the intervention, because she didn't have childcare, her 5-year-old would always be present. And so it was difficult even to kind of teach, but we wanted to do it that way because that's what her day-to-day life is, right? It's not, it's not worth it removing or getting childcare just for that 1 hour so that you could teach, because working through those problems are what she's going to need to do. But for everyone else, it was highly, easy to implement. The intervention helped their child improve social communication. The intervention helped them better communicate with their child, and they would recommend it to families similar to theirs. Here's this, just another measure of social validity and kind of meaningful outcomes. So this is kind of what was happening in mealtime before, and then with just some strategies and applying. So a lot of the previous behavior had to do with escaping the meal time, right? If I start throwing it on the floor, I'm going to be done. And so teaching the parents how to create a different functional communication for the child to escape mealtime, as well as not having the food available for them to throw off their plate. So small little strategies can make a big difference by training the parent and really creating a more peaceful mealtime for them. Some of the other meal results that changed, so on the MChat, what parents went from no to yes. So if you point at something across the room, does your child look at it? Does your child try to copy what you do? If something happens, does your child look to your face to see how you feel about it? So parents were seeing a lot more referencing. So what they would say at the beginning was no, something happens, the child doesn't look to me, as you saw in the videos. By the end of the intervention, they were saying this happens a lot more. And this is something that begins to happen anywhere from 7 months to a year, so it should be fully intact, by 12 months, and at least happening somewhat of the time. So it's not just kind of maturation or a developmental milestone, because a lot of these are things that should be happening prior to the first year that emerge after. Just for context, I just thought I'd throw in some typical development of what eye contact or what babbling would look like. Actually, my niece. You can see larger affect and that continuation. So not even just that brief eye contact, but just a social game of like, let's make a game of just smiling and laughing. And babbling. So a lot of the children you saw were quite quiet. So a few limitations to my research in general. So it's difficult to assess how much time each parent's spending on this because it's things that are worked on throughout the day, as well as based on kind of how much time they have, other siblings in the house, how motivated they are, how much success that they're having that they feel like they're reinforced and want to try. So we had no tracking on how much they were practicing this. And difficult to control for both prior knowledge and just kind of what they were learning throughout. So if I referenced, Sally Rogers in the Early Start Denver model, parents might buy her book and then start to read that. And so there can be not necessarily multiple treatment interference, but just learning, difficult to kind of control for how much they know coming into it, as well as ongoing. This study doesn't use a random control trial, so there are other studies out there that do. So Green et al. In 2008, they did a larger random control trial, I think with about 56 kids. So half the kids got treatment right away and half got a wait list. Because the time sensitivity of this treatment and because every month counts, ethically I did not want to do a random control trial and wait list control group kids. So that's why we chose to do a multiple baseline instead. So some future directions. So additional ABA replication, so without specific training and training guides, potentially the curriculum I put forth, but just BCBAs tackling this issue without needing to fall under specific branding. The stability of diagnosis, so looking at, in many of the kids that you see in these videos, by 18 months, they did actually receive a diagnosis of ASD. So even after the treatment, their symptoms had decreased greatly, but they still did receive a diagnosis for most of them. In BC, where I live, so the province of British Columbia, a diagnosis is attached to funding. So when they're diagnosed, they receive funding for intervention. So it is a benefit, if your child is diagnosed, that you are receiving funding, and the sooner the better. This pilot study that Sally Rogers did, where by 3 years of age or 36 months, 6 of the 7 children no longer met criteria. If we were to do that with this sample, so if the kids that you saw by 3 years of age, it would be interesting to see how many would still receive the diagnosis. It's hard because it's not in their best interest at this time to lose the diagnosis because it's attached to funding, but something to consider with most of my sample was diagnosed because they were diagnosed so early, compared to other research that waits till 36 months and then sees if they're still meeting criteria. What I found, especially anecdotally, is which profiles of parents are best suited for parent-mediated intervention. So the parent that, if there's a stay-at-home caregiver where they've got full-time, if it's their only child and they don't have other siblings to deal with or to, that occupy their time, they seem to be the best candidates, right? Parents that had multiple kids or that work part-time, they're just spread quite thin, and so that's where we might want to consider definitely still training the parents, but maybe a hybrid model of some intervention with a therapist along with parent-mediated might be better suited for a parent profile like that. And then as future BCBAs or already BCBAs or clinicians in this field, ABA is not just a treatment for autism. And so as behavior analysts, what we do is we evaluate the excesses and deficits of behavior. What's this child currently doing, what should they be doing, and creating the program to get from A to B. And so they don't need a diagnosis for you to help with that, right? It's just outlining the same task analysis that you would do just because they do have a diagnosis. And so what it involves is familiarizing yourself with the developmental milestones, determining the goal, and developing individualized teaching plans. So not to shy away just because they don't have a diagnosis, because we're not an autism-specific treatment. So we're treating the symptoms and not the diagnosis. And that's all. Thank you.